Hello and welcome everyone. This is Symposium 2, which is Assisted Outpatient Treatment in Los Angeles County, Implications for Involuntary Outpatient Services Nationally. The chair and discussant is Erin Kelly from the University of California, Los Angeles, and I'm going to turn it over to the group to introduce each other and proceed. So welcome.
Good morning. How's everybody doing? I hope you're all less jet-lagged than we are. So this morning we'll be talking about assisted outpatient treatment. And, oh, we're missing a slide that I was expecting with the overview. But essentially today we'll be talking about how AOT is used nationally and then locally in Los Angeles. Dr. Sarah Starks will be talking about the outreach and engagement period that's a unique feature of Los Angeles AOT. And then Ryan Doherty, who's a graduate student, will be talking about how violence and victimization impacts the process of AOT for both clients and for other key stakeholders such as family members and mental health providers. So to start, we wanted to give you a brief overview about what AOT is and why it happens. So there's typically very little public discussion of our mental health care system for people with serious mental illnesses unless there's been a violent tragedy, such as a mass shooting or a school shooting. And so this typically leads to discussions about the need for involuntary care for people with serious mental illness. So stepping back, when we look at the literature on the rates of violence by people with serious mental illness, we actually see that people with SMI are more likely to be the victims of crime or violence than to be the perpetrators. Now, there are exceptions to this. People who have comorbid substance abuse issues are, of course, at higher risk than if they just have mental illness alone. But I just wanted to point out that almost a third of people in 5 of the largest studies that have ever been conducted on this topic have been a victim in the 6 months prior, while only a quarter were perpetrators. And part of the challenge here is that we have a lot of difficulty engaging people with serious mental illness into treatment. So 62.9% of adults with SMI receive services in the prior year. And there are several reasons for why this happens, one of which is that oftentimes people with serious mental illness lack insight into the fact that they might need treatment. And so in the National Comorbidity Study, 55% of those who did not participate in treatment in the prior year said it's because they didn't believe that they had a mental illness. And we see that medication refusal is often the way that we tend to define treatment refusal. But I will point out that with AOT programs, at least in California, that medication is not a mandated part of treatment. So nationally, AOT has been rapidly adopted in the last few years. And so 46 states and Washington, D.C. have all legally mandated AOT. It's known by many different names, both nationally and internationally. Some of you may be more familiar with things like mandated community treatment, involuntary outpatient treatment, community treatment orders, or in certain states it's known by the victim that was the event that inspired the passage of that legislation. So it's known by Kendra's Law in New York, and in Laura's Law, it's named Laura's Law after Laura Wilcox, who was killed along with 2 others by someone who had untreated mental health issues. So California passed Laura's Law back in 2002, but the state has had an uneven implementation process that we'll discuss as well. But first, the AOT criteria, these are the California criteria, but they're largely similar across the US. You have to be at least 18 years old, you need to have a mental illness, you need to have a history of noncompliance, and Another key feature is usually you have to be at risk to yourself or to others, but not to the degree that would necessitate what we call a 5150 or a 72-hour hold. People need to be gravely disabled, and in California, you need to be able to benefit from treatment. And the idea here is that AOT is supposed to be the least restrictive setting to receive services. Okay, so in 2014, we conducted a national study where we called stakeholders across the U.S. to see how AOT was operating in their state. And we found that at the time there were 44 states that had AOT. There were only 20 programs that were actually active and that were comprehensively sort of getting any sort of statistics about what was going on. And we discovered that there were basically 3 main models for recruitment into AOT. The first is a hospital or jail transition pathway. And this is the kind that's most commonly been studied in states like New York and North Carolina. And essentially the idea is that people who have been stabilized, either in inpatient hospitalization or are coming from jail, are basically given sort of like mental health probation when they get back to be restored back to the community. Another model is what we're calling a community gateway pathway. And this is where we recruit people who are completely uninvolved in treatment, and we're just taking them from the streets and trying to get them engaged into services. And then lastly, we have what we called a surveillance or safety net pathway for people who are considered at particularly high risk, and it's a way of increasing monitoring of people that we're concerned about. And so states can have one or multiple forms of these pathways depending on how they've chosen to implement it. So does AOT work? Well, there are a lot of studies that suggest that there are several benefits to AOT, including lower odds of arrest, reduced risk of victimization, lower risk of harm to self or others, reduced emergency room visits. Some studies find reduced hospital admissions. Some find that it reduces the length of hospital admissions, and that there's higher quality of life associated with involvement in AOT. But interestingly, the higher that people felt coerced into AOT, the lower their quality of life that they reported it as well. But it is important to note that in one study that examined coercion between those who were court-ordered treatment and those who were in voluntary care, 72% felt that they felt high levels of coercion, but 63% in the voluntary services group also felt that way. So coercion is, of course, a broad concept that we could have a whole other panel about, and can involve inducements such as through the offering of benefits of treatment, not just through threats. And Sarah Starks will talk about that in a bit. But there are some important limits to the evidence. So most of the research has been done on the first pathway that we talked about, the jail or hospital transition model. And that creates like a neat timeline for like, okay, this is when people start AOTs, is when they've left the hospital. And it can be a bit murkier when we're talking about just pulling people directly from the community as to what their circumstances were before involvement in the program. It's also not perfectly clear that coercion has been the critical ingredient in AOT programs. One of the criticisms that is raised against AOT programs can be that when we create AOT programs, we create more resources to address the problem, and that it is the addition of resources, not necessarily the coercive aspects of the involuntary care, that is driving treatment benefits. And in New York, they did an evaluation to see if the creation of AOT programs actually diverted resources from voluntary care, and they found that for the first 3 years of AOT in New York State that was the case, but then it stabilized thereafter. And there are also a host of methodological concerns, such as some studies not including a control group, retrospective study designs, non-random assignment into AOT, which you can imagine might be extremely difficult to convince jurisdictions that you get AOT, but you don't. Randomization can be a little bit controversial in this case. Non-random extension of AOT orders, so obviously people who need care longer need to have that not randomly administered, and also the exclusion of persons with violence in some studies. So to talk about AOT in California, we have 58 counties. We are a big state. And AOT so far has been adopted in less than a third so far. So again, the law was passed in 2002. And in Los Angeles, we didn't really start implementing it until after the Santa Barbara shootings, although for those who are familiar with that. And it's important to note that the gentleman involved in that particular incident would not have met criteria for AOT. But it galvanized the LA County Board of Supervisors, who approved AOT in 2014, and it was implemented in 2015. And we, of course, began our evaluation in October of 2016, so almost there. In Los Angeles, we primarily have a community gateway model, but there is some small percentage that is transitioning out of jails and hospitals. A unique feature of AOT in California is that there's 30 days of outreach and engagement services that are required before you can get a court order. So in previous studies with AOT in the jail or hospital transition models, they don't have an outreach and engagement component. But if someone has resisted treatment for more than 30 business days, then a judge can civilly order someone into what's called either a court order or a settlement agreement. And the difference between these is whether or not you are signing involuntary paperwork in front of the judge or just before you actually meet with the judge. So it's a little bit like playing chicken with being in court. In the AOT program, we have a unique system where the county provides the outreach and engagement services for people referred to the program. There's a 15-person outreach and engagement team that covers all of Los Angeles County. For those familiar with Los Angeles, it is quite the large geographic area. So they spend a lot of time driving around the county trying to find people. The typical length of outreach and engagement lasts about 53 days for people who are eventually selected to go into treatment, and it lasts for an average of 116 days for people who, for one reason or another, do not get referred on to treatment. Adding to the complications of this program is once you are assigned into treatment, there are 23 different providers across the county. 17 are full-service partnership programs. For those of you who are not familiar with this model, it is assertive community treatment, analogous, but considered slightly less intensive. The other programs are enriched residential service programs, which is mental health treatment that also includes housing immediately, either with the ERS or at a contracted board and care. So there's sort of an interesting process that Sarah will be talking about, what we call the warm handoff process. So once someone has been referred to the program, they've met criteria, the outreach and engagement team has convinced people that they should accept treatment or not. They're under court order. Then they have a process by which they meet with their new treatment provider, with the client, and try to help to smooth the transition, because the outreach and engagement team develops really strong relationships with a lot of the people that are referred to this program. Once they're in the treatment, the providers complete monthly assessments, And the Department of Mental Health has quarterly meetings with all the providers to provide guidance. And programs and claims data is provided to our evaluation team on a quarterly basis. So I'm taking too long, so I'm going to hurry up. Very quickly, I wanted to walk you through the flow of our AOT program because it is kind of a complex program. As of January 2018, there have been 1,302 individuals referred to AOT. Sometimes people can get referred more than once, though. Once they are referred, the outreach and engagement team investigates the case. There's a weekly meeting to determine if people meet criteria. Of the people referred, 35% did not meet criteria. And the main reasons that people did not meet criteria was that they were already receiving services that perhaps the referring party didn't know about, or they're referred to other services that are considered more appropriate. And then a smaller number of people are lost to issues such as not being able to find them, incarceration, conservatorship, not having sufficient hospitalizations to meet criteria, the inappropriate referral party, moving out of county, or deceased. This is a living program, so we have people with 14% who are pending determination, and of the 64% that met criteria, there were, after the outreach and engagement process had begun at that point, 31% of cases ended up being closed, and largely that was because they were not able to find them. This is Los Angeles County, so a large number of the people who are referred to this program are homeless, and it can be difficult to find them. Moving along very quickly. At present, there were 99 people who were receiving active outreach and engagement, and then 84% of those who had been offered outreach and engagement were referred on to a treatment provider. Okay, so I've really got to hurry. The program is primarily male. The referring party is, the largest group is a treatment provider, followed by family. Police provide a smaller number of referrals, and I will note that referrals from police tend to be the least likely to get past, to meet criteria, largely because they have the least amount of information about someone that they've seen on the street. In terms of substance use, 27% reported being current substance users, although there's a large amount of missing data because there's often not a lot of clarity about how actively people are using substances. And the most commonly used ones are marijuana and meth. Okay. In terms of race ethnicity, if you're familiar at all with the demographics of Los Angeles, it is 28% white, 48% Hispanic, 9% African American, and 15% Asian. And so you can see that there are some disproportionate referral rates where we see black people are overrepresented, white are slightly overrepresented, but not significantly so, and Hispanics are underrepresented. And in terms of housing, 43% are homeless at the time of referral, but 25% are living with family. Basically, there are 300 slots for FSP programs, 60 slots for the housing version of the program, and it's 24-hour care, field-based, there are peer-run services, the goal is to provide comprehensive care to help people wherever they're at in terms of their treatment needs. Okay, so next I'm going to pass this on to Sarah, who will talk to you all about the outreach and engagement period.
So as Erin has mentioned, the outreach period is a really important part of this program and something we wanted to understand more about. And what I'm going to present now is all from post-outreach surveys that were completed by the outreach and engagement team. We asked them to complete one at the end of outreach for everybody that they try to engage in services. And the goal of this was to have a better understanding of all the clients who receive outreach, not just those who end up in treatment where we end up with different forms of information on them, and also to understand how the outreach and engagement process works. So this survey was developed in collaboration with the Outreach and Engagement team. So we asked them to come up with, well, I'll show you the lists of checkboxes that they would be working with. And they completed it in REDCap with an online survey that we have access to through UCLA's CTSI. The survey is ongoing. It was rolled out in July of 2017, and there are 320 surveys that have been completed to date. But what I'm presenting here is from about the first 6 months of the survey completion, so through January, 158 surveys. The demographics of this population, of the outreach population, again, it's about 2/3 male, 7% Asian, 19% Black, 34% Hispanic, 36% white, and 4% multiple or other. And you can see it's heavily weighted toward the younger age cohorts, toward those under age 40, and then tapers off in the older age categories. Diagnostically, you can see that it's heavily people with schizophrenia and other psychotic disorders, 13% bipolar, 6% mood disorder, other or unclear diagnoses. And the source of referral, 29% of referrals come from a clinician or hospital, 29% from a family member, or a DMH psychiatric mobile response team, or a joint DMH law enforcement team. 10% from social service agencies, and 4% from law enforcement or probation officers that are not part of a joint mental health team. And then the reason for outreach ending, 50% of the outreach clients ended up in AOT voluntarily, 4.5% were involuntary via court order, and 4.5% involuntary via settlement agreement, which, as Erin mentioned, takes place. There's one public defender who works with the AOT program, and she has a team of social workers, and she often convinces the clients to be found. And then there were some other reasons, including 2 clients who were deceased. So one of the things we asked the outreach team about was family involvement. A lot of these individuals are referred by their family members. We asked whether the client has contact with their family. 13% had no contact, 17% limited or only by phone, 20% have contact but they live separately, and 39% live with their family members. And then for 11% of clients, the outreach staff didn't know. Of those with contact, we asked for them to characterize the quality of the relationship with the family. In 18% of cases, they said there were primarily positive interactions, 49% a mix of positive and negative, and 14% primarily negative interactions, and with 19% they didn't know. And then we asked about how involved the family was in the client's mental health care. 6% were not involved, 28% somewhat or inconsistently involved, and 53% very involved. So this is, among those receiving outreach, there's quite a lot of family involvement. But as Erin mentioned, there are a lot of homeless clients involved in this program or referred to the program, and they tend to disappear more often. So by the time you get to the outreach stage, you have lost some of the individuals who don't have involved family, because those who have family are easier to locate. Now this slide, as a background, so we asked them to let us know if the family was interested in being involved in treatment and if the client was open to that. A background for that is that in this program, when someone is receiving outreach, they're not anybody's client. So they're not subject to HIPAA protections. And the family is often the referring party or is being outreached to along with the client or assisting with the outreach. There's a lot of interaction between DMH's outreach team and the family members, and they're sharing information back and forth. But when a client enrolls with a provider, at that moment, HIPAA applies, and if the client doesn't sign a HIPAA waiver, then all the information stops. And for the family members, this often feels like the door is slammed in their face. They don't know whether their family member is actually receiving the services. They may feel that the provider needs information that only they can provide, and they're not being given an opportunity to provide it. So DMH gets a lot of feedback from family members that they're really frustrated with this. So we were interested in knowing how much interest is there from both parties in having that involvement happen. And the squares that are in green are when both the family and the client are open to or very interested in involvement. So those are kind of opportunities for collaboration. And then the squares that are yellow, those are instances where we don't think that involvement will happen, but it's also not a conflict because nobody is strongly preferring the involvement. And then the red squares are where there's a strong conflict between the client or family wishes. We actually didn't have any individuals where the outreach staff felt that the client strongly preferred involvement, but the family was opposed. But there were 7 clients where the family strongly preferred involvement, but the client was strongly opposed. We asked about the support that the family is providing to the client. 17% only were providing no support. 51% were providing housing, 45% emotional support, 50% transportation, 19% medication assistance, and 7% were a representative payee. And then there was a free response option, so there are other kinds of support listed, but those are probably much more common than those percentages would indicate. Those are just instances where the outreach staff thought to write that down because it came to mind unbidden. And then we asked about whether the family had any ongoing issues with the client. So 38%, the outreach staff noted no ongoing issues, but 50% had concerns for family safety, and 11% had a restraining or protective order against the client. So that's a pretty big safety concern in this, and we'll learn more about that when Ryan talks about violence and victimization. 5% had concerns about theft from the client. 10% they indicated other kinds of ongoing issues, but again, that was free response, and we would expect many of these to be much higher, especially concerns for client safety. That's a pretty, ethnographically, we see that a lot, especially when clients are homeless or when family members are concerned about interactions they might have with police or other people in the community. So in addition to the family involvement piece, we asked the outreach staff about barriers that they encountered to engaging clients in treatment. We asked them to indicate whether a barrier was present for the client or whether the issue was present, and again, that was from a list that they helped us create. So we asked them, okay, here's our preliminary list, what other things are likely to come up? And then there was also the option to indicate other issues. And then if the issue was present, we asked them to rank how severe of a barrier it was for the client. So in this slide, you can see if the length of the bar indicates the percentage of individuals for whom the issue was present, and then the color shows how severe of a barrier it was. So red is a serious barrier, orange is a moderate barrier, yellow is a minor barrier, and then blue is not a barrier for that client. So you can see that there are a lot of mental health issues that were substantial barriers for many of the clients: lack of insight, paranoia, anger issues, substance use, lack of motivation. And then we asked about trauma history for the client. So most common is that many of the clients have prior hospitalizations, and often these have been traumatic for them. And then there was a pretty small percentage where the outreach staff were aware that the client had a trauma history of victimization, either physical or sexual abuse. But again, that's coming from the outreach staff, not from the client. Attitudes and behaviors could serve as a barrier. So resistance to medication was very common, distrust of mental health providers, and threatening words or behaviors from the client to the outreach staff. So very often in initial meetings and sometimes ongoing, the clients are pretty unwelcoming of the outreach staff. They also noted immaturity. Again, this is a pretty young population, and many of them are still living with their family members and may not be quite ready to acknowledge, based on where they are in their illness, a need for treatment. Client circumstances pose a challenge: lack of housing, legal issues, lack of resources, family mental health issues, family interference with treatment, and immigration status. And then background, sometimes there are cultural issues and language barriers that were a barrier. And then finally, these are pretty uncommon, but when you go to meetings, these are the things you hear about a lot in this program. Since a lot of the ERS program, which is an IMD step-down program, Some of them are scatter sites, so they house clients in licensed boarding cares, and there are licensing restrictions. So if clients have an arson history or a sex offense history, they can't be housed in these boarding cares. And it creates a pretty big complication because, of course, you don't want to put somebody who's a threat in a housing situation with a lot of vulnerable people, but at the same time, everybody needs a place to be, and that hasn't really been solved. And also, sometimes clients have medical issues that exceed what a board and care or ERS feels like they're equipped to handle. And then insurance, private insurance is actually the biggest barrier. This is a public program, but there is no private AOT program. So DMH's perspective is that providers need to enroll clients that are privately insured and then attempt to bill the private insurer. And the last time I saw this discussed, the medical director was hoping that someone would actually get a written rejection from an insurance company so that he could take it to the insurance commissioner, because there is no alternative version of this program. But I think that's still an ongoing challenge. So to summarize, client mental health was frequently an issue and could be a pretty substantial burden. Threatening words or behaviors could form a barrier. Barriers related to mental health treatment were common, past hospitalizations, distrust of mental health providers, and resistance to medication, which was often serious or moderate barrier, although the AOT program does not mandate medication, so clients get enrolled and still have a choice whether they want to see the psychiatrist, whether they'll agree to medications. And actually that's often a source of family frustration because they kind of hoped that this would be mandated medication. Client circumstances are very challenging. A heavily homeless population and housing placement and insurance status can be a big problem when it does occur, but it's not that common. And finally, we asked about the outreach strategies that they use to try to overcome these barriers. And again, we were asking them to indicate, before we get to that, we asked where outreach took place. This was a check all that apply. So 38% in the client's home, 23% in the hospital, 18% on the street, 13% in jail or juvenile hall, 7% at a family member's home. So they're going all over the place and often multiple places per client. And as you saw from Erin, this outreach process lasts for a long time. So there's a lot of attempts at connecting. And we asked them to indicate which from a list of strategies that they had helped us come up with they used with a client, and then whether it was effective for that client. The strategies fell into 3 different categories: services provided to the client during outreach, services advertised to the client as benefits of treatment, so telling them what treatment would entail and why it would be helpful, and legal strategies. So the strategies that were services provided during outreach, they actually split over 2 different slides. They assisted clients with many things, such as accessing medical care or other programs, getting ID, housing, helping them with family relationships or legal issues. They often referred family members to NAMI and worked with family and worked with that relationship to try to get the client into services. And then we also see that they used a lot of motivational interviewing, psychoeducation to the client and especially to the family, bought food and items for clients, provided different kinds of support, crisis support, emotional, informational, transition from incarceration, support during legal proceedings that the client had going on. And then most common, we see services advertised to the client as benefits of treatment. So they would tell them about assistance with employment, with going back to school, reintegration, benefits, case management. Groups and socialization opportunities is actually not as commonly mentioned, and that's because these full-service partnership programs are field-based, and many of them are treating clients who don't want to come into a treatment setting, so groups are not as big a part of the treatment as you would see in other outpatient services, although the ERSs rely very heavily on groups because they have clients in a residential setting. And then substance use services and therapy. And you can see that medication and substance use services are the 2 that for some clients were counterproductive, which is the red. So blue is very productive, very effective, green somewhat effective, orange not effective, and red counterproductive. And finally, when those outreach strategies didn't work, then often legal strategies were used. So even if they're not pursuing a court order for a client, there are legal repercussions mentioned to the client. With over half, they advised the client that they could or would pursue a court order, and with almost 20%, they did pursue the court order. And also with about 15%, they advised the client that they could pursue a 5150, which is California's term for a 72-hour psychiatric hold, and they did pursue a hold with 20% of the clients. In about 10-12% of instances, they advised the client that they might face jail or probation violation, and what looks like about 1% of cases, they reported the client to law enforcement or a probation officer. They sometimes assisted in conservatorship proceedings against a client, and then often they suggested, or maybe 20% of the time, they've suggested mental health services as jail diversion, or they worked with a public defender to divert a client, or they suggested that participation might prevent future arrests, jail time, and hospitalizations. So those latter two categories are kind of more in like the coercion light kind of category, whereas some of the top categories are much more heavily legal. So to recap, a wide array of strategies were used, and things that were effective with one client might be counterproductive with another. And the outreach staff really kind of exhausted everything that they had at their disposal to try to engage clients. Predominantly, we see them providing support to the client and families and telling them about the benefits of treatment. But when that was not enough, legal strategies were used, including discussion of court-ordered AOT, psychiatric hold, and mental health treatments as jail diversion. And so overall, our take-homes from this survey, that this is a very challenging population to engage. There are many barriers to engaging the population, and often they're severe. And on the positive side, there's a lot of family support for this population, although providing this support can be extremely taxing on the families, which is often why they've gotten to the point of referring the client. And then with the outreach process, they used a wide variety of strategies, and nothing works for everybody. So it's not like you can look and say, oh, that was a pretty effective strategy, that's just what we should do with everybody. You really kind of have to try a lot of different things. And finally, there were extensive efforts to engage people voluntarily, and we saw 50% of these clients enrolling voluntarily, 9% court-ordered or signing a settlement agreement, and 8% conserved. But even when we have clients enrolling voluntarily, we can see that there is a strong role for the possibility of involuntary treatment. So even though there is this voluntary option, clients know that there's the potential for a petition if they don't enroll voluntarily. And with that, I'm going to turn things over to Erin again, yes?
Okay. So the next stage is we're going to be talking a little bit more about how people flow through this program, particularly in respect to whether it's voluntarily or involuntarily. So as I said earlier, the vast majority of research has been on purely involuntary programs. One exception that I found was in New York State, where they, depending on the county, some of them had more extensive use of a voluntary option. And so this was earlier on in the implementation of Kendra's Law, but they did an evaluation where 23% of those enrolled in AOT were voluntary and 77% were involuntary. And they found that for people who are currently in AOT compared to their pre-AOT period, those who are under a court order were less likely to be arrested. So a very limited evaluation in terms of outcomes, but there was some indication that the involuntary aspect was a critical ingredient for helping people refer to AOT. So the main questions we had is, for this talk was, does a court order influence whether those who are referred to treatment actually enroll in services? And then does a court order influence whether or not you complete services or if you're discontinued early? And we'll get into that. So going back to our lovely flow diagram, at this point we'll be talking about
this section over here, where people are getting referred to the full service partnership programs or to ERS services. People who are paying attention to the numbers will see that 152 and 478 does not equal 512, and that's because people are often referred not to just one treatment provider, but to many treatment providers. Particularly with ERS facilities where there are a lot of restrictions on whether or not someone get in, the county will sometimes just assign someone to all 4 providers at once and hope that they get into one. So once you are referred to FSP services, then we have people who are pending enrollment because, again, it's a living program. And then we found that 25% did not enroll and 66% did enroll. I hit the wrong button. And this seems to be an unrecoverable mistake. The reasons why the main reasons why people don't enroll is either that we can't find them or they get referred to a lot of providers and they hopefully will enroll with someone, not necessarily. For the people, who are in services, we have majority of people are still getting services. This is a young program, so we don't have as many graduates yet. And then you can see that about 28% of people have graduated and 29% have been discharged. So it's about 50-50 whether or not people graduate or if they discontinue treatment early. And you can see that there's about a little over 4 months on average before people discontinue services, but there's a lot of variability in that. And that's actually a little bit longer than some other AOT programs. I believe in New Jersey, the average time before people discontinued services was about 90 days. So why do people not finish treatment? Well, part of it is we lose them. 29%, it was because we were unable to locate them. So because this is a program where we're pulling people in directly from the community, a lot of them are homeless, some of them have substance use issues, it can be extremely challenging to keep track of people and to find them, and so people disappear. Now, I will say that many times people get re-referred to the program, and so we try to pick them up again later, but it is an ongoing challenge. We also see that 18% end up incarcerated. So as our illustrious presenters earlier this morning discussed, we do have a problem with jails being often our de facto mental health system, and we do have problems where even once people are trying to get them into treatment, they're still getting arrested. And you also see that 13% are conserved, which is actually often the outcome that many families are hoping for when they refer people to AOT, because then they can require medication and things like that. Enriched residential services. So the intent of enriched residential services is that they're supposed to be for those who are perhaps more severe than people who are referred to FSP. But because of all the restrictions that we have on ERS services, when we look at clinical ratings on what's called the Multnomah Clinical Ability Scale that's completed on everyone, we actually see that people who are referred to ERS tend to be higher functioning than people who start at FSP programs. And that's because after the ERS facilities say, no, we can't take this person, they're either too sick or they have too many other problems, then the FSPs will take them on because we don't want to just completely not treat someone. The key feature here is that we have a much higher discharge rate than graduation rate for people in ERS facilities. Many times it's because people don't want to be there. ERS facilities have a lot of rules. And when you're pulling someone off the street who is in perhaps crisis, who is not stabilized in terms of their substance use or their mental health status, they don't want to stay. So we lose a lot of people to not being able to locate them. Sometimes we lose them to hospitalization or incarceration. Sometimes people just leave the county. And then sometimes people are actually not a failure. They're doing well enough that they can get transferred on to FSP services. So, in terms of the demographics of all the people who are referred to the program, I just wanted to remind people of some of who this population is. Again, so we are dealing with a heavily homeless population at the time of referral. But by the time we start whittling people down into actually getting referred on to treatment, we actually see that those who get referred to FSP are 33% homeless, and slightly more are referred to ERS facilities are homeless. And largely what we see is that just through every stage of the program, from meeting criteria to getting passed on to services, we lose people who are homeless, and the people who are most likely to be retained are people who are living with their family. So the family is actually sort of a critical ingredient for a lot of people in terms of keeping them engaged. And there aren't any race or ethnic disparities in terms of whether or not people meet criteria or whether or not they get referred on to treatment. But again, we do see that African Americans are overrepresented, and Hispanics tend to be underrepresented in this treatment population. And you'll also see the important issue here of current substance use. 36% of those referred to FSP, and 50% of those referred on to substance use treatment. And I will say that current substance users tend to be about 2 years younger on average than non-users. So the legal ingredient. At some point after the referral, about 9% of this population ends up conserved. So some people may consider that a negative outcome. A lot of times the families consider that a positive outcome because they're able to mandate medication, or they're able to get more intensive services for their family. And about 50% of that is after people are actually enrolled in services. So LA County was very careful about starting to use court orders when they first started the program. So in the first year, there were no court orders pursued. But since 2016, we've seen an increasing rate of court orders being obtained. And so we had 26 court orders and 35 settlement agreements. Functionally, these are the exact same thing, though. It's just a matter of where you sign the paperwork. In terms of whether or not people enrolled based on their court-ordered status, we see that the majority of people did enroll in either an FSP or an ERS when they had a court order or settlement agreement, but there is a smaller fraction that did not enroll. In terms of the timing of court orders, so as we talked about before, court orders can be obtained either before you start treatment, but in LA County, we also use it sometimes when people they've enrolled, but they're not really showing up. They're not engaging. And so 35 individuals were enrolled with a court order before they started treatment. 12 people were court ordered and never enrolled, as we saw before. And then 14 individuals had a court order obtained after they were enrolled, trying to really help people engage. But we do see that across individuals that we have a fair number of people who never enroll in services, and about 90% of people actually enroll voluntarily. Basically, I just wanted to highlight the fact that there weren't any demographic differences in terms of who had a court order pursued or not once they were referred to treatment. In terms of what the outcomes were, of our graduates, only 7% were involuntarily committed, and 93% were voluntary. And then we had 10% that were amongst those who left treatment earlier, who were court-ordered. I know I keep hammering home the demographics, but when we're talking about a program like this, we really want to understand what the population is and how it might be whittled down throughout the referral process. And the main thing to highlight here is that housing status, connection to family, or being homeless really makes a difference. And so people who are enrolled involuntarily are 25% homeless and 33% with family. And people who don't enroll are 42% homeless and 23% with family. When the family members are involved, it does seem to make a little bit of a difference in terms of more coercive tactics being used, because they're heavily advocating for that. That substance use is also a key factor here, so that people who are enrolled voluntarily are slightly less likely to be using at present. And as a reminder, that's of course largely marijuana and methamphetamine, some cocaine, alcohol are some of the top 4 substances people are using. In terms of the demographics and who graduated, we see that genders are roughly the same. People who graduate tend to be slightly higher in age, and we see that people who live with family are more likely to graduate. And our race ethnicity breakdown does not differ across discharge and graduation rates, but we do see that people who leave services early are using substances more likely. Okay, so does the court order work in terms of predicting whether or not you enroll in AOT? Well, so far, not quite. We have a trend level effect that the court order is related to enrolling in services, but again, because this is an ongoing evaluation, we'll have to see how that pans out. We recently received our last data set to look at the first 3 years of the operation of the program, and so we'll see how that changes because of the rapidly increasing rates of use of court orders. We expect that might change. And then in terms of your likelihood of graduating from AOT, the court order does not predict whether or not you will graduate, but whether or not you are using substances does. So if you are less likely to complete treatment successfully if you are currently using substances, which may not be a huge surprise to many people in this room. Okay, so AOT is a complicated program. As was said earlier today, if you have seen one AOT program, you have seen one AOT program. And LA County's is particularly complex with our 23 providers. Across the rest of the state, there's usually only 1 or 2 providers that are providing all the services. And we see that it's often a lot of these other factors, such as homelessness and substance use, that might be a bigger predictor of whether or not people are ending up in treatment or not, and whether or not they finish. There are a lot of challenges with trying to deliver this set of services to a homeless population. But really, as much as possible, when we can engage the family, that seems to make a big difference. But I will point out that in the studies that I discussed at the beginning of the presentation, when we talk about the rates of violence, in one of the studies, 51% of the people who are the victims of violence by people with serious mental illness are family members. So family members are often the ones who bear the biggest brunt of the safety concerns for this population. So for families, this is a very contentious emotional issue, as a lot of them do feel under threat. So to continue that, Ryan will talk about violence and victimization.
Okay, great. Hi, my name is Ryan, and I'll be presenting to you today violence and victimization for participants, family members, and providers in AOT. So AOT is framed as a public health response to violence, and research demonstrates that when violence is perpetrated by people who meet criteria for severe mental illness, it's usually within residential settings, and our data demonstrates that family members are really concerned about violence. Importantly, though, we know that people with severe mental illness are more likely to be victims of violence rather than perpetrators. So we see in the literature a range from 17 to 56.6% of the population have reported being a victim of some sort of crime. And we know that folks who are victims of crime tend to have higher symptoms of psychotic symptoms, and these have led to outcomes of increased homelessness and a lower quality of life. So putting things into context here for our project, unfortunately this photo looks really dark up here, but I would like you all to consider LA County and the issues that Los Angeles County faces. So this is a photograph I took underneath the 10 freeway. The 10 freeway is a major throughway which cuts through Los Angeles. Underneath these freeways are a lot of homeless encampments. So what you'll see is, nope, is this the button? Oh, here we go. So you'll see here are vans in which people are sleeping in. And there is a figure of a man standing right here who is barefoot and mumbling to himself as he's walking underneath this freeway. So this is actually a really common sight in LA. The 2018 Greater Los Angeles homelessness count has an estimate total of 52,000 people who are homeless in LA County, 24% of which are folks who have serious mental illness, and only 1,000 of those people with serious mental illness are actually housed. We also have a huge issue with the incarceration of people with severe mental illness. LA County and our jail system has been referred to multiple times as the nation's largest mental institution. The daily average of people with severe mental illness in our jail system for the first 2 months of 2018, the daily average was almost 5,000 people. What do we see in our project? So we see really high rates of violence and self-harm upon referral. So 77% of people who are referred to AOT have had at least one instance of violence towards others, and 49% had at least one instance of self-harm. When we look at the treatment phase, I broke it up here by the ERS, the housing, and the FSP, the field-based services. We see that this drops off quite dramatically. And in the later part of this data, so from January 2017 to 2018, we even loosened our definition of violence to any type of physical aggression to see if we'd be able to capture what's going on, and we still see really low rates of victimization and violence. So what's going on here? So as it's already been discussed, we know that not everyone who's referred to AOT is actually enrolled in services. And we're also seeing really high rates of discharges. Usually this is because, as Sarah and Aaron have pointed out, issues of incarceration, people are lost to follow-up, they walk out of the ERS facility and they're never seen again. And this is part of the unique challenges of delivering AOT, right? You have a population who are relatively new to services, who have been out of service for a while, so they're not as stable, and they have less resources. What I'd like to present to you today are my findings from a research ethnography I've been doing in the AOT project. And one thing that I have noticed in my ethnography with family members and treatment providers is that the fear of the client perpetuating violence and being a victim of crime are actually really central to the ways in which clients in AOT are managed in both the outreach and treatment process. And it might help illuminate what's going on with these statistics. So for those who are unfamiliar, ethnography is when a researcher immerses themselves in a culture or social setting to understand a social phenomena or process. It's on the ground, in which you take time to interview folks, you observe the treatment space, And you essentially write down everything you've seen, or you transcribe the interviews, and you go back to your research team. In this case, we were really lucky to have an interdisciplinary research team of social workers, anthropologists, psychiatrists, and we also have the quantitative data to really unpack what's going on in the data here. So I would like to present to you my two cases from my ethnography during the outreach phase of AOT. So this is a photograph I took in the north part of the valley in Los Angeles, and it's a little difficult to see on the slide here, but this is a homeless encampment of one individual, and he's collected all his belongings and shopping carts and sleeping bags and set up his living situation here. And he was referred to AOT actually because community members set his belongings on fire, and the local police were concerned for his safety and referred him to AOT. So what we've observed is that the referral process begins because some family members are concerned for their own personal sense of safety. Consider the case of Carlos, a young Latino man in his 20s. Carlos was referred to AOT by his mother and sister. I observed the end of the outreach process, where an outreach worker is handing off Carlos to Dr. M, who will be his new AOT treatment provider. I meet these two on a particularly rainy day in a motel parking lot, and we're at a motel because the family was kicked out of their apartment because of Carlos's violent behavior, and they've been jumping from motel to motel ever since. In this meeting, Dr. M says that they'll try to get Carlos housing as soon as possible. Carlos says he wants housing somewhere nearby, somewhere in the valley, and Dr. M says he'll try his best, but that first Carlos will need an evaluation. His sister and mother are shocked at having to pass Carlos through another evaluation before they can house him. They tell Dr. M he's been evaluated plenty of times at different hospitals when he's been violent, sometimes being rejected entirely for being too violent to receive services, and they feel like nobody is taking their crisis on their hands seriously. From my notes, I write, Dr. M begins to explain to her how the system works. They evaluated him and didn't admit him because maybe he wasn't deemed a threat to himself or others. But Carlos's sister's anger is rising. She pushes her hair back, rolls her eyes, and raises her voice. She asserts her point that yes, she understands that's how the system works, but the system isn't listening to them. Every day, Carlos screams at his mother, calling her a bitch, that he wants to rape and murder her, and even still they have trouble admitting Carlos. And she stresses this has been going on for years. The mom wants Carlos in housing as soon as possible. They don't care that he's requested housing in the area. Anywhere that'll take him would be good enough because they can't handle jumping from motel to motel anymore. It's expensive and exhausting and humiliating. Here, family members are referring a person to AOT as a means to protect themselves, to put an end to their unstable housing situation. These family members expect AOT to provide what previous services could not: guaranteed enrollment and immediate housing. But clients are also referred to AOT because they might be rapidly deteriorating and vulnerable to harm. Consider the case of Diane. This is a client who's referred to an ERS facility from an agency on Skid Row. She has an unknown history, having shown up to an agency one day out of nowhere, and she rarely communicates. In this interaction, another outreach team is performing a handoff to an ERS facility. Olivia, the social worker who made the referral, facilitates the process. She has sent Diane practically all over LA, begging her for her to be admitted to multiple hospitals and agencies, some of who rejected her for being too cognitively impaired to receive services. Despite non-enrollments and discharges sending Diane back into the streets, she somehow miraculously finds a way to Skid Row and wakes up every morning on the doorsteps of Diane's agency. In my notes, I write, the handoff itself is fairly short. Throughout, Diane is incredibly calm. When she responds to questions, it's often very difficult to understand her. She mumbles when she talks, if she does talk. Olivia, the social worker, sits right next to her and sometimes offers up translations to the team. Diane really wants to move into housing. She gives us a clear and affirmative yes when asked. She then mumbles something to Olivia, and Olivia responds with, "No, nobody will be raping you at night, okay? The ERS facility will take good care of you." While Diane spoke little throughout the interaction, her repeated appearances at the agency demonstrate a persistence to receive support, and her concerns of sexual violence in the housing facility demonstrate a vigilance for her own safety and an awareness of her own vulnerability. Importantly, these perceptions of violent perpetration and victimization are not only motivating factors in themselves to refer people to AOT. It is accompanied with an underlying hope, even desperation, that AOT might be the last chance in an otherwise unhelpful system. Once enrolled in services, perceptions of perpetration and victimization continue to play a central role in the delivery of services. Consider the case of Christy, a young African-American woman living in South LA. My first meetings with Christy were at her mother's home, where her therapist conducts treatment sessions, and we later learned that Christy is actually sleeping in a broken-down car on the side of the street. Christy isn't allowed to sleep in her mother's home because her mother is worried about her niece's safety. This is despite the fact that Christy has never been outwardly angry or violent towards her. She can't stay at her father's house, who she does have a history of violent behavior towards, because he's worried about his own safety. And both parents refuse to send Christy to a shelter or a board and care facility because they are worried about her own safety and that she might not get along with others. Christy is painfully aware of how her family thinks about her. In one meeting where her therapist is talking to them about housing options, she suddenly reveals this hurt. From my notes, I write, the therapist asks where they could look for housing. Christy says nearby. That way she can easily visit her mom during the day. Christy then, to our surprise, says she doesn't want housing, but somebody is kicking me out, she yells across the room. What's that? Her mom yells back and then storms into the living room towards Christy. Christy tells her mom that she wants to sleep here. She doesn't want her own place. Her mother takes a deep breath. In a controlled voice, she tries her best to explain that she can't have her sleeping at the house because of her niece and isn't sure what she'll do to her. Christy looks furious. You think I'll do something to her? You think I'd hurt her? Her mom points her finger and says, well, we don't know. Sometimes you get mad at her. Christy argues that she has never, ever hurt her. But the mom goes on saying that Christy's a very independent person and she really needs her own place. Christy doesn't respond, looking dejected, and she returns to her coloring book. And don't think she isn't listening to me right now, even if she doesn't look like it. She's always listening, she says to me. In spending most of her times on the street, Christy experiences victimization. The police will disturb her at night to tell her she can't sleep in the car, often escalating into verbal confrontations. Christy had her skateboard stolen, which is her primary mode of transportation across LA. At another point, Christy jaywalked across the street and was tackled by a police officer for it. She resisted and was promptly brought to the hospital and placed on a 72-hour hold. It is impossible to bring up these experiences of victimization with Christy directly in her treatment sessions. They're deeply, deeply hurtful for her. This example demonstrates how concerns of perpetration and victimization can be at odds with one another. Within housing, there are concerns of perpetration. While homeless, there are concerns of victimization. All of the actors, family members, providers, and clients have concerns and experiences in regard to their own safety. And in negotiating these concerns, here in terms of housing and homelessness, these actors are forced to reckon with these concerns and with no clear solution at hand. The concept of trauma and victimization is discussed among providers and family members alike in AOT. In my observation, sometimes perpetration and victimization are actually intertwined with one another. Take, for example, Christy's resistance to being tackled. Now consider the experience of Darian. This is a 20-year-old Latino man who has spent the last 3 years in jail and is now in an ERS facility. I conducted an interview with Darian, though his therapist strongly warned me not to, telling me that he's too violent. He was actually a very sweet person. When I conducted the interview, he disclosed a lot to me, and we discussed his feelings towards medications which he resists. His medications were doubled in the first week in being the ERS facility, and this is an excerpt from the interview in which I asked him, does he know why his medications were doubled? Did she, his psychiatrist, give you a specific reason? Darian: Yeah, she said that I was acting up, that I was being very aggressive, horseplaying, not following staff instructions. I ask, how do you feel about that? Do you feel like Darian? I kind of was doing that, but I don't know. Like for me, I was just, in my mind, I was going to be in a place where there were going to be pretty grown men. I was pretty sure that one of them were going to try and punk me. You hear me? So I got to show him nobody going to punk me, you know? Here, Darian's treatment provider is modifying his treatment in response to his violent behavior. But for Darian, his violence is in response to his traumas of incarceration, feeling scared and wanting to protect himself. So what have I demonstrated here? AOT may be a public health response to violence, but the fear of violence, both in terms of perpetration and victimization, are woven throughout clinical interactions and family dynamics, and are not resolved through more intensive services. The social actors I described here have their own sets of fears in regard to their own safety, which have informed their decision-making in terms of why AOT is applied and how those services are negotiated. Further, the service providers are often used to relying on things like ERS to house clients, but suddenly these are no longer applicable to the specific concerns and experiences of this population. Second, we must also think about the ways victimization and perpetration are interrelated for clients, who at times might act out in ways that are actually rooted in their own past experiences of being victims to violence. That is, we should consider expanding our understandings of victimization to include how and when clients experience themselves as victims and the types of fearful or protective behaviors which might follow. In our observations, and demonstrated here with Christy, the policing and criminalization of homelessness can be considered a form of victimization as well. This is a photograph of a tent on Skid Row underneath a sign which outlaws sleeping on the street, as an example. Last but not least, I think that this also demonstrates the importance of mixed methods research in evaluating mental health services. We can understand who's enrolled in services by quantitative data, but actually understanding the ways in which these programs are negotiated, I think, are best demonstrated through the use of qualitative data. Thank you. And, unless you want to... Great, so this is our evaluation team. A special thank you to the PIs, Joel Braslow and Philippe Bourgois. And then, as I mentioned, we have 3 data collectors who are responsible for the quantitative data. We have a group of ethnographers. And we also want to thank all the folks at the LA County Department of Mental Health, and also all the clients who've allowed us to enter their homes and collect their experiences and data on them.
I saw that gentleman first.
So homelessness is take-home medicine.
It's a big one.
Yeah. So obviously the ERSs have housing, although it's a housing that most people don't want. I wouldn't want myself or a child or any friends of mine. What are the other housing options that the full service partnerships have to offer?
They have, depending on the agency, they have different sorts of resources available to them for housing. So one agency has permanent supportive housing, another agency will have contracts with board and cares, some agencies have housing specialists, some don't. It sort of depends on where you live in terms of which agency you're connected to primarily, and then how big or small that agency is or how well prepared they are to deal with the clients. So there can be a lot of variability. Some of the board and cares are perhaps challenging for people to be in. They may not match well in terms of like their age or their experience with, a lot of board and cares in LA have a lot of people transitioning out of jails or rehabilitation centers. But largely in LA, we have a housing crisis. Some of you may have heard about this. housing in LA is extremely expensive, and this year the the homeless count suggested there is a 4% drop in homelessness, and the county passed several measures with the voters, Measure H and Measure HHH, to help improve the amount of housing and supportive services, but we are finding that the replacement rate is really damaging our ability to make a big impact. So it's a ongoing huge crisis for us, for sure. Yeah. Did you have?
Yeah, just a quick definition on graduation. When you say somebody graduates,
This is a tricky thing. Graduation in this program means that the treatment provider has decided that this person has met their treatment goals. And so those treatment goals are highly individualized. Many times when people graduate from services, they are connected to a regular FSP program. So the difference between AOT and FSP and regular FSP is there's a 10-to-1 ratio of provider to clients for AOT, and 15-to-1 for regular FSP. And the majority of clients who leave FSP do continue on with services, although we're still tracking to see how long they stay in those services. Graduation ostensibly means that they have recovered enough that they can participate in a slightly less intensive version of services. Yeah.
It seems AOT is the public health response to violence, and yet individuals who may be at the highest risk of violence, individuals with comorbid substance use, individuals who are violent and threatening during the intake process, people who are frequently incarcerated that might derail the intake process, they seem to have the hardest time accessing services. And I wonder how conversations in your agency are around that. I do similar work in New York, and it's hard to engage this population who most needs it.
Yeah. You guys can jump in as well.
I mean, I'd be happy to speak to this point ethnographically. And I think Sarah's data also speaks to this, is that rapport actually goes a really long way. And in our ethnography, before any services are provided, it could just be a matter of visiting the homeless encampment that this person's sleeping at once a week and bringing them McDonald's. And building this sense of, I think there's a sense of, among a lot of participants, a broken trust with the mental health care system, and they don't understand my needs. They don't know what I need in my life. And so if that can be rebuilt, I think it's actually, it goes a really long way of inviting people into services, making them feel like perhaps these providers know actually what their needs are. But I think that distrust really is, it really does stem from victimization, and the trauma that people have experienced in prisons, in hospitals.
And in terms of like what we're doing, as UCLA researchers, we applied for a CDC grant. Hopefully we'll get it, because to centrally look at the violence and the victimization aspects, because it does seem to be such a huge factor for how people relate to treatment, whether or not they get in it, how they stay in it, and how much family support is available to them. Because unfortunately, getting into AOT does not necessarily mean that you stop being violent, and we've had some pretty bad incidents. Yeah. Yeah.
I just had a question about substance use
Sure.
treatment. Is it typically part of AOT programs, and what types of substance use treatment are offered?
Again, 23 providers. Some of them have a lot more experience and have more resources available to them. For example, one of the providers has their own inpatient rehabilitation center that they can send people to. And so if people are assigned to that treatment provider, and they might be more likely to be assigned to that treatment provider because they have more experience with substance use issues, if they have substance use issues. But because of the geography of Los Angeles, it might be very difficult to convince someone to go an extremely far distance in order to get that treatment. And so we interviewed all of the providers at the beginning of when we started our evaluation, and we do 6-month interviews periodically to check in with people. And some of it depends on how much turnover they've had in terms of how experienced their staff are with dealing with these issues. And it's kind of not a neat answer. Yeah. Saw someone back?
Yeah, so along those same lines with the substance use, I saw that it was statistically related to the likelihood of graduation, and you mentioned that you guys kind of had an idea of what the most abused substances were. I was wondering if you had considered or looked at breaking down the outcome by the substance of choice.
So that's something we hope to do now that we've had our 3-year data set, is to look more comprehensively at these risk factors that we've been noticing. I don't think it would be very surprising to a lot of people that methamphetamine is probably going to be related to not staying around in treatment. Methamphetamine is, of course, a huge issue in Los Angeles. While the broader nation has more of an opiate crisis, we continue to contend with meth, which some people can use adaptively. I use that word very oddly. If you're homeless and you're worried about being victimized on the street, sometimes people will take methamphetamine to stay awake in order to avoid being victimized. But then that exacerbates their symptomatology, and as you can imagine, there is quite a big feedback loop that happens there for people. Yeah. Yeah.
So I'm just curious about the substance of the court orders or the settlement agreements for those who go one of those two routes.
Sure.
I think I understood something Sarah said to suggest that it's not typical, or in fact, it's as a matter of policy not done that the court order will direct the person to comply with medication. Is that right? I mean, are they
It's not a part of AOT. That it would be a separate hearing that you would need to have done. One of the reforms that the county is trying to contemplate is to how to maybe integrate a separate medication order hearing as a part of the involuntary court order process. But that's not currently how that is done, and necessitates a lot of people signing off on that before that will happen.
So is the sense then in California, in at least, that to include medication as part of what a person's court order to do, you would have to have the findings necessary for what we call researing, right?
Mhm.
The person
Yeah.
Yeah.
has capacity to make treatment decisions.
Correct.
So that's typically what's required to actually forcibly administer medication.
Correct.
It's interesting and a little concerning to me that that's has been interpreted to mean that you can't direct a person in a court order to do it. I mean, there's a difference between saying, a court saying, this is what I'm directing you to do on one hand, and on the other hand saying, now we're going to forcibly administer those meds because you haven't done it.
So, and to clarify a little bit, AOT cannot mandate medication, but they do try to get around it a little bit, where the judge will say, you are mandated to comply with the treatment plan and with everything that is in the treatment plan, and the treatment plan will include medication, but they are not allowed to specifically order medication. So the hope is that the client won't kind of overthink that and will assume that they have to comply with everything. But again, there are no consequences associated with AOT. Yeah, so it's a challenging, and different providers have different feelings about this. So the FSPs are supposed to be a recovery-oriented program. They see treatment as very voluntary, and they're kind of trying to thread this needle of, okay, we have court-ordered clients, and yet we want to tell them, you know, you make choices, we come up with goals together. So it's complicated, but yeah, the medication piece is definitely frustrating for a lot of people.
And the challenges of the court order's limitations are,
Great session, great questions. That wraps up this part of the program. We're breaking now for lunch. Please be sure to visit the poster sessions. Today are posters that were competitively submitted for the conference. Tomorrow there'll be posters from the new investigators, and we hope that you'll go and visit both of them. Thank you.